Well, good morning and welcome, everyone. Jim Brett here at the New England Council. Delighted to welcome you to this month's installment of Inside the Corner Office. We get to know some of the men and women who are leading the businesses and organizations that are driving the region's economy. Before I introduce our guest today, I wanted to take a moment to quickly tell you about a few other programs in the next few weeks. We will host Capitol Hill Report breakfast sessions with Senator Sheldon Whitehouse, Congressman Seth Moulton, and Congressman Jim McGovern. We're looking forward to a New England Innovates program on October 25th, taking a look at some of the incredible work underway in our region to combat Alzheimer's disease. Senator Ed Markey will keynote that program on October 25th here in Boston. And our biggest event of the year, our 2022 annual celebration, is now less than a month away. The evening of November 7th, we will honor 4 incredible New Englanders of the year, as well as a Lifetime Achievement Award with hundreds of our members and friends at the new Omni Hotel, which is located in the Seaport District here in Boston. But today we're honored to welcome Dr. Joanne Conroy, the CEO and president of Dartmouth Health. Dartmouth Health is Northern New England's largest health systems and includes its flagship Dartmouth Hitchcock Medical Center, as well as community hospitals, clinics, healthcare services across New Hampshire and Vermont. It is New Hampshire's only academic health system and the state's largest private employer. Dr. Conroy joined the organization as CEO in 2017 and bringing with her a wealth of healthcare leadership experience. Most recently, she was the CEO of another New England Council member, that's Leahy Hospital here in Burlington, Massachusetts. And prior to Leahy, Dr. Conroy served for more than 5 years as Chief Healthcare Officer for the Association of the American Medical Colleges in Washington, D.C. She's also held a variety of other leadership and academic roles with institutions throughout the East Coast. We are delighted that she could join us today to share a little more about her own background and the incredible organization that she leads. Welcome, Dr. Conroy.
Thank you, Jim. It's a pleasure to be here.
You know, we always like to start these conversations by getting to know our guests just a little bit better on a personal level. So to start, just tell me, what inspired you to pursue a career in medicine?
Well, when I left Dartmouth College, and I was a class of 77 here, I think the second class of women to graduate from the college, I really wasn't sure.
Isn't it a class of 97? I had
77.
Okay, all right, okay.
You know what? I wasn't sure what I wanted to do. So I took the med boards, the law boards, and the GREs, just to cover my bases. And after 2 years, and I had worked actually on the Cape for a while and dated somebody that was on one of the NHL farm teams, but that's a very different story.
Okay,
And
all right.
and then worked at Woods Hole at the Marine Biological Labs. I decided to go to medical school. And I wasn't sure that I would like it. You know what? I know that a lot of young people want to be 100% sure before they do anything. But, you know, I felt if I was 51% sure that it was the right thing to do, I should do it. So I applied to medical school and actually end up at the Medical University of South Carolina in Charleston. My parents were residents of the state at that time. And they really, I interviewed and they offered me a position about 3 weeks later. So I hate to say that my tuition was only $800 a semester in 1979. So it was the right move from a financial perspective as well.
Well, you mentioned that you went to Dartmouth, but you were among the first Coed classes at Dartmouth College. Tell me how that experience impacted you.
So it taught you resilience, long
Mhm.
before resilience was a popular word. I would say that there were a number of the male students that actually welcomed us, but there were a number that really resented us being there. I do remember when I was a freshman, walking into the dining hall and saying, I'm not going to sit alone. So I just introduced myself and sat down at a table of male students. I found out later that they were the entire baseball team, but they were actually very nice to me. And you just learn to kind of overcome, any reticence or insecurities you had, and just, stick your hand out and introduce yourself to somebody. And that's actually stood me in good stead.
Wow. And you're an anesthesiologist by training. What prompted that interest in that specialty?
When I was going through my training, there wasn't a really deliberative process of trying to match your talents with the specialty. And we are way better at that now in medical school. But
Mhm.
back then, you were kind of left to your own devices to figure out what you wanted to do. I actually had considered surgery, but I had enough self-awareness that my personality type, which is like never leave the hospital until every T is dotted and I is crossed, I probably would never have left the hospital as a surgery resident. So I looked at other specialties and liked anesthesia. It was actually very kind of hands-on, action-oriented. We talked about it as 90% boredom and 10% terror. And it was probably a really good match for me, because there was the end of the day when the cases were done and the ORs were finished and you had to go home.
Mhm. But you made the transition from practitioner to hospital administration. What sparked your interest in moving into that kind of leadership role, and what was that transaction like?
I'm probably a accidental leader rather than an intentional leader. I was serving as vice chair in a department with a new chair who'd been there about 7 months. And I was on call, and the business manager showed up in my office in tears. And I said, yeah, Brenda, what's wrong? And she said, we can't make payroll. So then starts the fact finding about what's actually going on. And frankly, the way we ran a lot of practices, they were kind of PAs back then. We were federated within a group practice then in South Carolina. I said, well, just give me the spreadsheets, and went through the spreadsheets, and it was really obvious we were spending far more than we were bringing in. And then I had to kind of take the steps to talk to people in administration and the practice plan, and talk to the chair. And it was really interesting that our chairman was a nice guy and a great researcher, but really didn't know how to run a department, and didn't have the infrastructure, didn't have a good business manager who knew how to really collect for the work we were doing and appropriately allocate expenses. So I was kind of drawn into kind of helping the department get out of that. And you know what, when you do good work and it gets recognized by other people. And so I was asked to do many more things. Within 3 years, I was not only the chair, but the VPMA of the hospital. And within another 2 years, I was senior associate dean. And all of that really around identifying and fixing some of the both financial and operational problems that really affected a lot of academic medical centers in the mid-90s. We were not very businesslike across the country at that time. After the Balanced Budget Act, we actually got a lot smarter about how we ran our organizations.
Your career has taken you all over the country. You mentioned South Carolina, Washington, D.C., but you returned to New England in 2014 when you became the CEO of Leahy Hospital here in Massachusetts. And then a few years later, you go even further north to Dartmouth. What drew you back to New England?
My family is from rural Maine, and we're from Parkman. So we have actually property in Dover, Foxcroft, Maine. And It's kind of that touchstone for us. So we have a special place in our heart for Northern New England. My husband at the time, who unfortunately died the first few months of COVID, he said, aren't we going in the wrong direction? Like everybody else as they get older move south and we're moving north. And I said, no, I think we're going in the right direction. So, and, you know, I love being here. It's been a wonderful experience for me.
Let's just shift gears a little and talk more about the incredible organization that you lead. You know, we've had other healthcare CEOs as guests in the series, but they've all been from, you know, the Boston-based institutions. Dartmouth Health, however, serves a very different population in a much more rural region of New England. Can you talk about some of the unique challenges for a rural health system?
Dartmouth Health is actually the most rural academic medical center and health system in the country. We have fewer than 170,000 people living within 30 miles of our flagship academic medical center. The closest to us would be Mayo, which has about 240,000 people living within 30 miles of Rochester, Minnesota. There are significant challenges running an academic medical center in a rural part of the state. And rural is different. Rural in New England and rural in Minnesota and rural in Nebraska all have different flavors. For us, rural means we serve a population of patients, many of whom don't have the resources that would be accessible to people in a more urban or suburban area. They are often poor and associated with their low socioeconomic opportunities. They're often far less healthy. We have problems with transportation, believe it or not, affordable, safe housing. And you would probably be surprised that in rural America, there is significant food insecurity that affects our patients. From a employer perspective, it's harder to recruit people to come live and work in a rural part of the country. Now, the people that we recruit are all in for living in probably one of the most beautiful areas in Northern New England. They leave work within 5 minutes. If they've got a kayak on the top of their car or a mountain bike on the back of their car, they can be out in beautiful wilderness within 5 to 10 minutes from the academic medical center. It's incredibly unique in that way. In fact, somebody said once, I wonder if the people that work here, do they live to work or work to live? Because people are really very interested in outdoor activities. But frankly, 25-year-old young nurse who is looking for a little bit more than the nightlife we have here, which is, you know, the sidewalks kind of roll up at 10 o'clock. It's not going to be very satisfied with committing their career at that age to a rural part of New England. Now, we do try to kind of hang on to them and stay in contact with them when they decide to settle down to kind of reconsider coming back here. But I think that's one of our biggest issues with a lot of our young nurses. They want to get out and see the world. And what's interesting is the cities that they're actually interested in. Austin, Texas, and Nashville are some of the kind of top cities that young nurses want to go to. And they meet a lot of other young people. Once they get 2 years under their belt here, they're ready to see the world, and we're just hope that they'll come back when they want to settle down.
That's interesting. We talk a lot about health equity, often in the context of serving communities of color. But health equity is also an issue in rural areas. Can you tell us more about the work of Dartmouth Hitchcock's Center for Rural Health Equity?
Sally Kraft has established the Center for Rural Health Equity, which is taking a very broad look at the disparities just within our communities. Before I came here, I actually pulled the CDC health outcomes data for both Grafton County and Sullivan County. And it is amazing the difference in the predominant health conditions between the two counties that are adjacent to each other. And if you actually take the average lifespan of somebody that lives in Hanover and compare them to somebody that lives in Claremont, it's only separated by probably 20 miles. It's close to a 20-year difference. And the geography and the zip code makes a difference in their longevity. And a lot of it has to do with poverty, education, transportation, all the things that when you look across population health variables across the world, that people that have reliable transportation, people that have safe housing, people that have a job, people that have access to fresh food actually are healthier and live longer. And we see that within our own communities. Now, Sally Kraft and her team have done a fabulous job, and we have really benefited from Senator Jean Shaheen's support in federal funding to really look at health equity across rural New Hampshire. And there are specific interventions that Sally and her team are taking. And some of that focus on access to fresh food, and some of it focuses on sustainable housing and transportation.
As a result of the pandemic, we've seen a huge uptake in the use of telehealth. Can you talk about the role of telehealth at Dartmouth Health and how it's been useful to ensure access to care?
Dartmouth Health invested in telehealth probably 8 years ago. We started to seriously invest in infrastructure so we could create a telehealth provider to provider network. So we have over 25 hospitals across New Hampshire, Vermont, and Maine that actually use our telehealth services. Our services offer ED services to rural emergency rooms. We offer stroke services. We offer tele-ICU. We offer tele-specialty care. And it's made a huge difference in allowing these small hospitals to keep patient care local when they just need to talk to an expert. And I would say in some of the facilities, they say it's an extra level of comfort when they just have to hit the telehealth button in the ED. If they have something frightening roll into their ED and they just want some help from the Dartmouth Health team. Our bunker is called Connected Care, and it has a big footprint on the second floor of the hospital. And we are staffed with physicians and nurses 24/7. We're not just selling our services externally, though. We're actually using our telehealth, for example, our ICU, to add another layer of oversight over our own ICU here at the Academic Medical Center, giving nurses and residents that kind of backup that they may need on a night or a weekend. If they just want kind of a specialty or a ICU curbside consult in terms of managing a very difficult patient. We have started to move into provider to patient telehealth. Of course, everybody did with the pandemic. We went from, I think, probably 5 telehealth visits a week to like 2,500 a day in almost 2 weeks. And I like to say that a single strand of RNA did more for our telehealth than millions of dollars of venture capital. I mean, we just figured out how to do it. And we have started doing tele primary care, tele urgent care to just kind of create greater access for our patients. Now, the aspect of rural healthcare is even more important. Imagine a patient that's got to come to see a surgeon after a procedure to have them examine a wound, but they live 2 hours away. Our surgeons can now do that with telehealth, saving that patient that visit and that drive. And so in rural parts of the country, it is incredibly convenient and actually creates a continuity of care that we probably wouldn't have without that telehealth option.
Just a few weeks ago, the White House hosted the hunger conference. And one of the topics that was discussed was the idea of food as medicine. I think you touched on it a little bit. And I understand that Dartmouth Hitchcock opened a cancer center food pantry earlier this year. Can you just tell us more about that? And then what prompted its establishment?
We work with a lot of our local partners. We've had conversations for a long time about setting up our own pantry, but the Haven, which is a local shelter and has a well-organized food pantry in White River Junction, is really our partner. So we work with them, and they have helped stock and give guidance for creating food pantries. We did one at the Cancer Center because a number of our nurses realized that some of these patients were having to make decisions about gas, heating, and food as they were going through their cancer treatment. Make no mistake, cancer is not only emotionally and physically a catastrophe for patients and their families, but often financially it is as well. And they wanted to do something, and the Haven actually helped them set up a food pantry at our cancer center. But it's not our only one. We have a program for moms in recovery, women that are in active recovery from opioid use disorder. And the Haven did the same thing. They helped us set up a pantry in the counseling center. So when those moms came for their counseling sessions, not only did they actually get food, we even have a diaper closet. So they got everything they needed in order to take care of their families when they returned home. And it has a lot to do with them actually staying compliant with their recovery.
Do you have any stats on how many families are affected by the food pantry?
So I think close to 400 people or 400 bags have actually been delivered from the cancer center. And I would say we're into the over 1,000 from our moms in recovery. It's a very active program, and that is a very active pantry.
Wow. There's been quite a bit of growth on your campus in recent months, from Geriatric Center of Excellence, expanded emergency department, new inpatient pavilion. Boy, it's needless to say, it's exciting times to be on that campus. But can you tell us a little more about these new facilities and how they will better serve the patients?
Currently, we turn away close to 500 acute care transfer requests. People that, because of the acuity of their healthcare needs, really should be admitted here. And yet we don't have any beds. When you think about it, we're actually quite small for an academic medical center. If you eliminate the pediatric beds and the bassinets, we have about 396 adult beds. And that is not enough to serve the aging population in New Hampshire and Vermont. And our footprint keeps growing. We probably should have built a tower about 5 years ago, but we are close to completion. They'll hand the keys over sometime in January in 2023, and it'll take us 2 to 3 months before we move our first patient in. On the 64 beds, we are going to open in April, but we have 2 other floors shelled out, so we can open another 64 beds. And the question is the demand increasing fast enough that we're going to have to do that earlier than we initially thought? That will actually help us really accommodate the growing need for complex care that we have here in the Upper Valley. I would say that we, like many other facilities, are struggling with our ability to actually move people to not acute care levels of care, to nursing homes, to long-term care facilities. And all of those have been affected by the staffing issues associated with the pandemic as well. This will just give us a little bit more breathing room. I would say when we look at our bed capacity, we're always in the red, and we're always kind of juggling patients. So we make sure that we take care of the most urgent and critical patients. But it's definitely a full-time job for a team running our transfer center and our capacity management board.
The New England Council focuses on federal policy. So we'd always like to take a few moments during these conversations to talk a bit about what's going on in Washington, D.C. Now, I'm sure you're well aware that Congress just passed that stopgap spending bill that extends coverage at least through December 16th of Medicare dependent hospital and low volume hospital programs. Can you just speak to the significance of these designations?
Yeah, those programs benefit many hospitals, but they absolutely benefit rural hospitals. And every single one of our hospitals serves rural communities. And it is critically important for those hospitals, especially with all the challenges that we're having on the kind of the backside of the pandemic with staffing and with labor costs. Those would have a hard time staying afloat without that type of support. Dartmouth Health is a single obligated group, and we all sit on the same bottom line, which gives a lot of those small hospitals a backstop that a lot of the independent hospitals don't have. But we remember that even though we don't own many of the hospitals that we serve through New Hampshire and Vermont, we depend on them to be financially strong because they need to take care of many of those patients in their community. We could not accommodate care for all of those patients should those hospitals falter financially. And that federal legislation is critically important for those hospitals.
You know, we talked a bit about the importance of telehealth and the challenges that a lack of broadband in parts of northern New England pose. Your thoughts on how that bipartisan infrastructure bill passed last year will help alleviate some of those challenges?
That is critically important. If we are hoping to deliver more care, either through telehealth or even home care, remote monitoring for a lot of these people to actually keep them at home, you can't do that without the broadband infrastructure. And I could tell you, you don't have to go very far out of Hanover to have your cell signal falter a little bit. And we were actually thrilled to see that there was going to be some real investment in broadband because it will make it far easier to care for many of our patients. We already have obstacles to caring for many of our patients in New Hampshire and Vermont. Our VNH, which is part of our health system, there are a lot of patients, they're driving down 4 or 5 miles of a gravel road to a house that has questionable internet in order to care for patients that don't want to come to the hospital. And, it's critically important that we be able to communicate with those nurses and also with those patients' homes.
My last question here, because I know you have a very tight schedule, but I think you'd agree that you have a wonderful congressional delegation in New Hampshire and in Vermont, who I know understand the challenges related to rural healthcare. But what more do you think could be done by our leaders in Washington to help support rural healthcare?
We spend a lot of time talking about what the future of healthcare looks like, Jim. The recent challenges that we're facing are probably different than ones we faced over the last 20 years. If you think about it, there are challenges for all hospitals that are cyclical. With the economy, we've seen that go up and down, and the changes in the workforce and the impact of inflation. There are some that are one time, and it's hard to believe we're going to call the pandemic one time, but the stimulus funds that they gave us were really addressing a kind of a single event and helping us all pull our ox out of the ditch and find a pathway to recovery. But what we're facing now across the country feels structural. It feels like 1998. I'll tell you how old I am. It feels like the Balanced Budget Act. And when 50% of the teaching hospitals in the United States went into the red in 1 year. And the federal government had to roll back a lot of that with the Balanced Budget Reconciliation Act. And there was a lot of important legislation that allowed hospitals and health systems to get back on their feet while they thought about how they reorganize their business. And everybody did that. we got a lot smarter about how we ran our health systems. And we went from not thinking about efficiency to really valuing efficiency and not wasting certain healthcare dollars. I feel like we're all back at that point where we have to say structurally, how do payments, federal payments for healthcare and state payments have to change in order to create a sustainable healthcare system? Because if we don't do that, rural emergency rooms and urban emergency rooms will start to back up, and we will not be able to offer the care to our communities that they expect and deserve. That is a huge conversation that probably
Yeah.
won't happen before the midterms.
Right,
But needs to happen at some point.
Yeah, no, I agree. Well, thank you, Dr. Conroy, not just for joining us today, but for the important and impactful work that you and your entire team at Dartmouth Health are doing to keep communities healthy. And to all of you who joined us today, I hope you enjoyed the discussion, and be sure to join us for our next month's installment of Inside the Corner Office, where our guest will be Cynthia Hansen, who is the president of gas transmission at Enbridge. And I hope you have a great and a wonderful day. Thank you.